Good evening. Honorable Minister of Health, Dr. Rajitha Senaratne, Guest of Honor, Professor Neena Modi, President and the Office Bearers of the Sri Lanka College of Paediatricians, distinguished guests, ladies and gentlemen. First of all, I would like to thank President and the Council of the Sri Lanka College of Paediatricians for awarding me the honor of delivering the CCDC Inauguration 2016. I consider it as a great privilege to be able to pay a tribute to one of the most outstanding paediatricians of Sri Lanka. Chamli Chalmers de Silva was born on the 25th of February 1904 and obtained his primary and secondary education from Bishop's College, Garment Training College, and St. Thomas's College, Mount Lavinia. He obtained MBBS and Doctor of Medicine degrees from University of London and was a member of the Royal College of Physicians in London. In 1949, he joined the Faculty of Medicine of the University of Ceylon as the first professor of pediatrics, and he was instrumental in developing the Department of Pediatrics in University of Colombo and the Professorial Pediatric Unit of Lady Ridgeway Children's Hospital. He was an excellent clinician, teacher, administrator, and a researcher. His tireless work as a clinician undoubtedly helped in combating malnutrition in Sri Lanka. He established the first malnutrition clinic in Lady Ridgeway Children's Hospital in 1956, and moving further, established the Thalagolla Convalescent Home for malnourished children, which still serves children with nutritional deficiencies and special social needs. Professor C.C. de Silva was a reputed academic both locally and internationally. He has numerous highly cited publications in high-impact journals of his time. One of his main research interests was hemoglobinopathies. And in fact, his pioneering work has led to the first description of thalassemia in Sri Lanka in this paper published in Archives in Disease in Childhood way back in 1951. Ladies and gentlemen, it's indeed a great pleasure to talk to you today about a novel method of treating thalassemia as an honor to the very first pediatrician who described the disease in this country. Thalassemia is one of the most common genetic disorders in the world. It is estimated nearly 70,000 children are born each year worldwide. Majority of them have transfusion-dependent beta thalassemia. Most of these births occur in the traditional thalassemia belt, which extends from sub-Saharan Africa, Mediterranean, through Middle East to South and Southeast Asia. However, due to recent migration patterns, thalassemia has become a health, social, and financial burden to many countries in the world. Thalassemia has been a long-standing health problem in Sri Lanka too. Thanks to the pioneering work done by several pediatricians, physicians, and scientists in the past, the burden of thalassemia is well studied and reported. The prevalence of beta thalassemia carrier state is reported to be 2.5%, and us as pediatricians care for around 3,000 children with thalassemia in the country. It is estimated that nearly 60 to 80 new patients with thalassemia are born each year in this country. Therefore, thalassemia still presents a great burden to the healthcare system in Sri Lanka. I believe a reasonable majority sitting in this audience does not require any introduction to clinical management of thalassemia. In fact, I had the honor of being taught by many of you on beta thalassemia as a medical student as well as a trainee in pediatrics. Patients with thalassemia present in infancy with pallor, growth failure, hepatosplenomegaly, and bone changes. They have severe anemia, which is invariably fatal without treatment. Patients with beta thalassemia require regular monthly red blood cell transfusions to maintain their hemoglobin at safe levels. However, regular transfusions carry significant risks and lead to numerous complications, including iron overload, which is the most troublesome. Excess iron gets deposited in body organs, including heart, liver, pancreas, and other endocrine organs, to lead organ dysfunction and organ failure. Even though 3 iron chelating medications are currently available to treat iron overload, none has been efficacious enough to produce optimal results. Therefore, patients with beta thalassemia still experience a relatively poor quality of life and die prematurely. The current standard treatment, despite being extremely costly, provides only supportive care and is not curative. The only curative treatment option available for thalassemia is bone marrow transplantation. However, this has several limitations. Firstly, bone marrow transplantation is only available to a minority of patients who have suitable donors. Secondly, it is associated with serious adverse events, for instance, graft versus host disease, which can be life-threatening. Thirdly, in developing countries like Sri Lanka, the cost of bone marrow transplantation is far beyond the limits which most people can afford. Therefore, it is clear that there is a great need for new, alternative, and effective therapeutic strategies for this life-limiting disease. Ladies and gentlemen, in this oration, I am presenting the findings of my journey in search for a possible cure for beta thalassemia, which was done as part of my studies leading to Doctor of Philosophy degree at University of Oxford. And understanding about the basic pathophysiology of beta thalassemia is required to appreciate the rationale of work presented here. In brief, adult human hemoglobin is composed of 2 alpha and 2 beta-like globin proteins, which are encoded by alpha and beta globin genes respectively. In patients with thalassemia, due to various mutations, the production of beta globin is either reduced or absent, as well as the production of adult hemoglobin. However, the synthesis of alpha globin continues normally, and this unopposed production leads to an accumulation of alpha globin within red blood cells. These insoluble alpha globin proteins precipitate in red blood cells and their precursors to result in hemolysis and ineffective erythropoiesis. Red blood cell destruction by these mechanisms is the main factor leading to anemia in patients with beta thalassemia. Therefore, we hypothesized, if we can control the production of alpha globin in patients with beta thalassemia, it should reduce the excess of alpha globin and destruction of red blood cell, and should lower the severity of anemia. This should invariably ameliorate the severity of beta thalassemia and reduce, or in fact eliminate, the need for blood transfusion in these patients. As the first step in validating this hypothesis, we examine the occurrence of this in nature. 4 copies of alpha globin genes are present in each human cell, and natural reduction of alpha globin protein is seen in patients with alpha thalassemia. Depending on the number of mutated alpha globin genes, the clinical severity of alpha thalassemia varies. Deletion of a single alpha globin gene is usually asymptomatic, whereas deletion of 2 alpha globin genes results in mild microcytic anemia. Deletion of 3 out of 4 alpha globin genes leads to hemoglobin H disease, whereas deletion of all 4 alpha globin genes leads to a neonatally fatal condition known as hemoglobin Barr's hydrops fetalis. Because of the higher prevalence of alpha thalassemia and beta thalassemia in some parts of the world, both these diseases can coexist. There are several case reports, case control, and cohort studies which described patients who co-inherit alpha and beta thalassemia. These studies have very well demonstrated that the presence of alpha thalassemia with deletion of 1 or 2 alpha globin genes is associated with a milder disease in patients with beta thalassemia. For example, if we consider these two kids, they have identical mutations in their beta globin gene to produce beta thalassemia. However, they have contrasting phenotypes. The younger child has severe anemia, marked hepatosplenomegaly, and has thalassemia major and is transfusion dependent. Whereas the older girl has very mild anemia, marginal hepatosplenomegaly, and does not require regular transfusion. The clinical phenotype of thalassemia intermedia. The reason for the less severe phenotype in this girl is that in addition to the beta thalassemia mutation, she also inherits deletions of alpha globin genes. The alpha globin gene deletions decreases the alpha globin excess in her red blood cell, thus reducing the hemolysis and ineffective erythropoiesis, leading to less severe anemia. Similarly, the studies which described co-inheritance of alpha and beta thalassemia have shown that patients with beta thalassemia who co-inherit alpha thalassemia have a less severe phenotype with old age at presentation, smaller hepatic and splenic sizes, normal physical and sexual maturation, less severe anemia, and reduced transfusion requirements. Further, these studies have highlighted that a reasonable proportion of patients with beta thalassemia who co-inherit alpha thalassemia are completely asymptomatic and live normal lives in community without coming to medical attention at all. We published these findings in a recent review article in the journal Blood, where we concluded that a reduction of alpha globin levels by 25 to 50% in patients with beta thalassemia should reduce or in fact eliminate the need for blood transfusion and could lead to a possible cure. However, to use this phenomenon as a therapeutic tool, we need to selectively reduce the production of alpha globin without affecting the production of beta globin. Is this possible? If so, how? Those were the two main questions which left us like this and sometimes like this. To answer above questions, we need to understand the regulation of alpha globin gene. Any human gene is controlled by three interrelated mechanisms: enhancers, transcription factors, and epigenetic mechanisms. With regards to alpha globin regulation, enhancers and epigenetic are the two major regulatory mechanisms. What are these enhancers? For those who are not familiar with genetics and molecular medicine, enhancers are DNA sequences that facilitate transcription of genes. Transcription of a gene is the first step leading to the production of a specific protein encoded by that gene inside human cells. In terms of alpha globin, a number of studies have identified a DNA sequence that is in the same chromosome as of alpha globin to function as the main enhancer of alpha globin. This is known as MCSR2. There are case reports of patients who have deletions limited to this enhancer, resulting in alpha thalassemia, despite having perfectly normal alpha globin genes. This confirms that MCSR2 enhancer is critical for the normal production of alpha globin in human red blood cells. As previously stated, the other important regulatory mechanism governing the expression of alpha globin gene is epigenetic regulation. Again, for those who are less familiar, epigenetics explain how cells in a multicellular organisms have identical DNA sequences, thus maintain different terminal phenotypes. In a simpler way, we know that every human cell has all the genes required to produce all the proteins which are essential for human body. However, only a limited number of essential and relevant proteins are produced in each human cell. For example, globin genes are present in all human cells, including brain, muscle, and intestinal cells. However, hemoglobin is only produced in red blood cells and not in brain, muscle, or intestinal cells. The reason behind this is, in non-erythroid cells, these globin genes are silenced through chemical modifications of DNA and the associated histone proteins. These silencing mechanisms are known as epigenetics or epigenetic regulation. Next, we review the current understanding of the regulation of the alpha-globin gene, which is published in journal Annals of New York Academy of Science. In this, we concluded that in human red blood cells, the alpha and beta globin genes are regulated by independent enhancers and different epigenetic mechanisms. We propose to utilize these differences to reduce the production of alpha globin without affecting the production of beta globin. During the next part of my talk, I am going to tell you about two independent approaches that we tested to reduce the production of alpha globin. Firstly, we utilized pharmacological interventions to target epigenetic mechanisms. Secondly, we tested an extremely novel molecular medicine technique known as genome editing to create a deletion of the MCSR2 enhancer to reduce the production of alpha globin. The first hurdle was to decide on a platform to test these therapies. Can we test these straight in humans or animals? The definite answer is no. None of the innovative therapies for human disease can be tested in humans or animals straight away. They must be first tested in preclinical in vitro models, that is human cells in laboratories, before proceeding to animal experiments and phase 1 clinical trials in humans. Therefore, we initially test our experimental therapies in human cells, and for this, we developed an erythroid cell culture system using human peripheral blood. In this system, hematopoietic stem cells are separated out from blood samples using a technique known as magnetically activated cell sorting. And these cells are then grown in the laboratory in an erythropoietin containing medium until they are expanded in numbers and produce large number of daughter cells. Morphological characteristics of the cells generated in the laboratory over 21 days show gradual differentiation of stem cells into red blood cells, recapitulating normal human erythropoiesis within the bone marrow. Next, using this culture system, we embarked on a search for a drug that would reduce the production of alpha globin without reducing the production of beta globin. When we reviewed the understanding of the regulation of alpha globin gene, it was apparent that the epigenetic differences are the most suitable target to develop drug therapies. Therefore, we decided to test a group of drugs which are known as epigenetic drugs. Epigenetic drugs act at different epigenetic pathways, and some of these have been already approved by the FDA for clinical use, and many others are currently in clinical trials. We treated erythroid cells with several epigenetic drugs in tissue culture plates and evaluated the production of alpha and beta globin by RT-PCR, real-time PCR. Results of this experiment is shown here. Upward bars represent drugs which increase the production of alpha globin, whereas downward bars represent drugs which decrease the production of alpha globin. As you can appreciate, few drugs demonstrated significant reductions in alpha globin levels in cells treated compared to untreated cells. Out of these, a novel epigenetic compound known as IOX1 showed the most promising results with the lowest alpha globin levels. IOX1 is an epigenetic inhibitor drug which inhibits histone demethylase enzyme, which is responsible for the removal of methyl groups from histone proteins. It's a new chemical entity which is not yet approved by the FDA, nor entered into clinical trials. We then tested the effect of a dose range of IOX1 on the expression of alpha and beta globin genes. This demonstrated that IOX1 significantly reduces the production of alpha-globin in a dose-dependent manner. There was no effect on the production of beta-globin, suggesting that IOX1 has specific action on alpha-globin but not on beta-globin. Then we evaluated the possible adverse effects of IOX1 on erythroid cells. Cells treated with IOX1 were morphologically similar and immunophenotypically similar to untreated ones, confirming that the treatment of IOX1 does not have significant effects on erythroid differentiation. Also, the expression levels of most other genes in the erythroid cells treated with IOX1 was similar to the untreated cells. In conclusion, these observations confirm that histone demethylase inhibitor IOX1 selectively reduces the production of alpha-globin without altering the production of beta-globin. IOX1 does not have significant adverse effects on red blood cell differentiation or gene expression, suggesting it as a suitable candidate drug to reduce the production of alpha-globin in patients with beta thalassemia. During the next part of this oration, I will talk to you about a very interesting and extremely novel approach of gene therapy to reduce the expression of alpha-globin gene, CRISPR genome editing. CRISPR genome editing technology was developed in the year 2013 and is considered as one of the greatest recent inventions in medicine. Invention of this technique has led to thousands of high-impact publications within a very short period. The basic principle of CRISPR genome editing technique is to mutate a specific gene by cutting at a predetermined target site in the human genome. This is commonly by creating a deletion within the gene. In simple terms, CRISPR reagents act as molecular scissors. As described previously, MCSR2 is the most important enhancer of human alpha-globin and is crucial for normal alpha-globin production in red blood cells. There are case reports of patients who have deletions confined to this MCSR2 enhancer having alpha thalassemia despite having perfectly normal alpha-globin genes. For example, this Portuguese patient has a homozygous